Hello, this is Miss Roberts. We're going to be talking about Chapter 21 in the Davis Advantage book, Caring for the Child with a Musculoskeletal Condition, starting on page 719. So on page 720, it's the review of the musculoskeletal anterior and the posterior pictures are in your book here. Just to give you a refresher course on anatomy. Going down to page 721, it starts talking about collaboration of caring with a child with musculoskeletal disorder. So just make sure you understand the difference between an occupational therapist and a physical therapist. So, physical therapist works with the gross motor skills and the occupational works with the fine motor skills. Okay, so gross motor skills and fine motor skills. On page 722, it starts talking about immobilization devices, casting of the child. This is just like a boot cast. This is an abduction bar or a short leg cast. So I want you to know that Wink and Lollipop, the two most common reasons for a cast change is if it becomes soiled or wet. If you notice a foul odor or drainage from the inside of the cast, this can be indicative of infection, and it needs to be reported to the primary care physician as quickly as possible. Some more Winks and Lollipops are here. Cast complications. Make sure you understand these. If the pain is unrelieved by narcotics or analgesics, I have that written down, or analgesics. Paresthesia, you know, that's the tingling sensation. And then I want you to add one down here that says inability to move extremity. Okay, so inability to move extremity. Some collaborative care. Here, some more Winks and Lollipops. Let the child kind of do the play with the cast. You know, give them a casted doll before applying their cast, just where they can see that the doll's not in pain, so to speak. And then make sure you understand how to do a neurovascular assessment. This is box 21-1. Then some modifications for a spica hip cast, and you'll see that picture here. Another Wink and Lollipop. So making sure that the child is allowed to sit in a wagon. That would be the easiest way to maneuver the child. In a stroller, they may be dangling their leg, and that would cause edema in the lower extremity. So sitting them propped up on a pillow in a wagon will be the best way to travel with a child instead of a stroller. So another Wink and Lollipop, okay? Let's go on and talk about cast care. This is a showering cover, just slides over it. Most of them have like a band that seals it at the end. You can get that at any type of medical equipment company. I know Ortho Georgia has a little store in Macon that you can buy those right there at the physician's office. So let's talk about some more cast care. So you want to reassure the child that they will not be injured from the cast removal. and make sure the parents understand that it may be the skin may be dry and flaky, muscles probably stiff once the cast comes off. So just, learning to reuse that limb again, just because it's been immobile in that cast. So make sure it's important wink and lollipop there, okay? I want you to write this down for cast removal. So skin may be caked with desquamated skin. That's DESQUAMATED, desquamated skin, and sebaceous secretions. And that's just that flaky, almost flaky wet coating on the skin just from it not being washed and kind of sealed for a few weeks. And the answer to this is to soak it in a bathtub. Okay, just tell them once the cast comes off to go home and soak that leg or arm in a bathtub, and they can wipe that dead skin off. Okay, so cast removal. Skin may be desquamated skin and sebaceous secretions. You should educate to soak in a bathtub. Alright, let's talk about tractions. The principles of the traction is to reduce, of course, immobilization and let that heal. There's a counter traction where it's kind of pulled in the opposite direction. I'm using weights and pulleys. Okay, there's skin tractions and there's skeletal tractions. So I want you to know this here, first paragraph, wink and lollipop. Make sure you understand what a Bryant's traction is. They lie supine with the hips flexed, and you can add the buttocks is elevated slightly off the bed. Okay, so that's a Bryant's traction. You see how this baby's laying in the bed, and the buttocks is slightly lifted. Okay. There's some more tractions that you can read through here. Dunlop traction. Read through these because I've heard that some of the PEDS Practice A questions has to do with traction. So you might want to read through these few pages, of course. You should be reading those anyway. Alright, let's talk about musculoskeletal conditions, most common ones. There's plagiocephaly, that's where the bony plates get separated by sutures. There's craniosynostosis, and it's the premature fusion of the sutures. And then we're talking about cranial sutures here. Okay. Torticollis, this is a stiff neck, a contracture in the cervical spine, known as twisted neck. And then clubfoot. Okay. And this is unfortunately pretty common. About 1 in 1,000 babies in the U.S. are born with club feet. Okay. About half of those babies are born with it bilaterally. Make sure you read through that. But they can do the CVS, which is the chorionic villus sampling, about 20 weeks or so, 17 to 20 weeks. And evidence-based practice has just proven that it may be contributed to maternal obesity, smoking, genetics obviously, but some environmental factors are maternal obesity and smoking. Amniocentesis can be done before 20 weeks. And then there's postural, idiopathic, neurogenic, and syndromic. So make sure you know what those are. And of course, like we said, the diagnosis can come about 20 weeks through the amniocentesis, CVS, or the ultrasound. Okay, so they can see these on an ultrasound. So what do? We do lots of physical therapy, and we do splints, we do cast. There's pictures of your splints in here where they're casted and then splinted across to keep them open. So when you're wearing a cast for club foot or cast for fractures, whatever, you need to know this patient education. Okay, so this is a wink and lollipop. Make sure you understand this patient education. What do we do as the nurse? All right, and then I want you to add one to the bottom. With extreme fussiness, go to the ER if the casted distal parts, like the toes, are cool to touch. Okay, so I'm going to say that again, and you need to add this bullet point. Okay, so with extreme fussiness, go to the ER if the casted distal parts, like the toes, are cool to touch. Alright, let's talk about DDH. This is developmental dysplasia of the hip. If you remember when I demonstrated the newborn assessment, the head to toe assessment, we do the Ortolani and Barlow sign, and you kind of roll the hips outward, inward and outward, just to see if you hear that click or anything. Okay, and so these are the signs and symptoms. All right. Ortolani maneuver is when they're flexed and the legs are abducted, and you see you check this for hip dislocation. The Barlow is the adduction, bringing the legs inward and downward while attempting to disconnect the hip outside the acetabulum. So just to roll those hips in and out, you're checking those for the DDH. Okay. So if you can look at this, you see this dislocated hip. This is on a 3-year-old, and this is kind of sitting outside. You see the dislocated hip outside. So for some treatment, you're going to use a Pavlik harness. That is the most common treatment for dislocated hips. Make sure you understand what a Pavlik harness is, okay? All right, let's talk about Legg-Calvé-Perthes disease. It's a multifactorial genetic and environmental condition. Usually occurs between the ages of 3 to 12. And the highest occurrence is between 5 and 7. Okay, so it's aseptic necrotic, like the femoral head, and you can see it in this picture right here, where this necrosis happens in the femoral head. Okay, several weeks they present with synovitis and decreased ossification. So I just want you to read this. This bone formation lasts a while, and then they have to get treatment. Diagnosis is with an x-ray, of course. So you see how it's just like the necrotic bone right here. Okay. There is no prevention. I mean, it just happens. And then you would have to get an orthopedic involved, of course, to have surgery and go through that. MRI's done, collaboration with the orthopedic team, providing braces, and they're usually worn for up to 4 years. but I just wanted to show you a picture of that. But that's called leg calf prothase disease. Okay, it's just really caused, the necrotic tissue is of course caused by inaccurate blood supply to that femoral head. And you can see it right here too. See how it's just flat instead of rounded like the other side. Alright, let's look at pectus excavatum, and that's what this picture is here. This is on page 732. It's congenital disease of the posterior depression of the sternum and costal cartilages. You see how it kind of caves in? It's a caving of those cartilages, okay? Not really understand why this happens, but they can develop some cardiorespiratory symptoms, especially when they're active. And, you know, of course, kids are going to be active, right? Usually happens in teenagers. And then surgical care involves, you know, reconstructing those and repositioning those bones. Okay. All right, polydactyly and syndactyly. This is where polydactyly is where you have more than 5 digits on each extremity. Okay, so you see there's an extra digit here, extra digit here. That's called polydactyly, more than the normal number. So that's why I tell you it's so important to count fingers and toes. Okay, don't just assume there's 10 fingers and 10 toes. You need to actually count them. Okay. Some are just hanging on by a skin tag, like this one. It could just be tied off, or actually there's bone, and if the parents decide that they want the digit removed, it would cause surgery. They would have to have surgery. So a lot of people are proud of this with their kid, like their great-grandfather had it and their grandfather had it, and they're like it's something that they're proud of in their family, so they want to keep it. You know, that's not to say the kid doesn't grow up and they decide to have surgery to remove it, but I've seen this several times. We had this just a couple of semesters ago, twice in that semester in Moultrie, so it does happen, and it's just genetics. That's just genetics. All right. Syndactyly is where there's webbing there. Okay. Let's see. And this is just the webbing in between the fingers or the toes, and they just literally go in and clip that skin and suture it closed. Okay, suture it where it's not joining. Okay, but they just go down and clip it. There's a little bit of reconstructive surgery there. All right, let's talk about soft tissue injuries. So this is sprains and strains, okay? This is not fractures. So, you know, lay people have a tendency to think sometimes that a sprained ankle or a strained ankle is a broken ankle. It is not. It's just a soft tissue injury. So bruising, swelling, inability to move that muscle without pain. So. And our answer to treatment for that is, of course, the Rice method, okay? And this is on page 734. You have different degrees of that, okay? But you need to know what this Rice is. This is Winks and Lollipops, okay? So, rest, ice, compression, and elevation, okay? So they need to rest it, ice it for up to 48 hours, and then after that, you alternate heat and ice, okay? And then compression, wrap it up in an ACE wrap, and of course keep it elevated above the heart. But Wink and Lollipop, you need to know what that is. Sports injuries, okay? And I said 48. After 24 hours of ice, then you go to heat. I'm sorry, I'll correct myself. So after 24 hours of ice, then you alternate it back and forth with heat, okay? Trying to reduce that swelling. All right, so with sports injuries, of course, you're using the RICE method, okay? So rest, heat, ice. After 24 hours, you start doing the heat, which aids in the healing and reduces that inflammation. Children needs extra protection, epiphyseal plate until they are, older teenager. So, let's see, it talks about it here. So your epiphyseal plate's not fused until they're about 17 or 18 years old. So make sure that you understand that they need to protect that, okay? Wearing pads on their elbows, pads on their knees, because everything is not developed until they're a little older. Osgood-Schlatter disease. Okay, this is a common knee pain, and this is just prevalent in usually boys. And this is talking about the RICE. We will watch these videos in class, and we will practice with ACE wraps. So, Osgood-Schlatter. This is where they have that little bump on the knee. Okay, see the little bump, kind of under here, right there. It's kind of, you can see that little bump, but this is just repetitive movement. They still have that where their knee is not completely developed, but it can be painful. So a lot of teen boys think, they've damaged their knee, when really it's just a painful, and it will resolve on its own. So make sure you understand that. Once it stops growing, that pain will go away. But you just see that little bump there. All right, let's talk about fractures. So we talked about the epiphyseal plate. If it is, and I want you to write this down, if there's a fracture to the epiphyseal plate, normal bone growth can be affected. Okay, so we don't need to be damaging that epiphyseal plate. Okay, big thing, Wink and Lollipop. Do not. Let me just highlight this whole thing. You don't want to damage that. It can cause deformity in the limb, blood supply being cut off. So that thick periosteum is what helps the bones to grow, increases blood supply, because that epiphyseal, the growth plate, when I say epiphyseal plate, I'm talking about the growth plate, is still open. So Wink and Lollipop, make sure you understand that. And then assessment tools, okay? Make sure you understand this, what happens, the separation of type 1, 2, 3, 4, and 5, and where it can happen. There's a case study on page 738. Make sure you do that, understand that, and put it all together. All right, now we're going to talk about osteomyelitis. This is a bacterial infection in the bone and the tissue around the bone. Okay, so this is a picture of that. Okay, very, very scary. Open fractures cause this, septic joints, blunt trauma, of course. So they can lose limbs from osteomyelitis. Make sure you understand that, Wink and Lollipop. Okay. Here. So big thing is that they need IV antibiotics, and this is long-term antibiotic therapy. Okay, this is not just a couple of days, but this is months and months of therapy, IV therapy. So home health gets involved, and they are checked several times a week, antibiotic therapy, okay? This is some x-rays of osteomyelitis. You see on the x-ray, you can see how the bone is deteriorating from that bacterial infection. You will see these pictures again, but this is osteomyelitis, okay? You see this here. Alright, juvenile arthritis, you can read through that. On page 743, it starts talking about scoliosis. And we've talked about scoliosis, demonstrated how to check for scoliosis. So just make sure you read through this again, understand that. Okay, normal spine. This is kyphosis, where you have that hump back at the top, x-ray of scoliosis. This is flat back, sway back, and kyphotic, which is that swaying out here, or going in here and swaying out here. It's kind of a mixed picture. Alright. And this is just the bend over test for scoliosis, right? Make sure you understand, Winks and Lollipops, that these teens are, of course, obsessed with their image, right? Body image is huge, major problem. Like if they have to wear a brace, is their body image. They don't want to be seen around their friends wearing a back brace for scoliosis. So they don't wear it, and then the scoliosis gets worse. They have to have surgery. So you just have to encourage them that it's cool to have a straight back, but you have to get the treatment in order to do that. Kyphosis is mentioned on page 745. This is just that hunchback, and lordosis is the sway back. Okay, so kyphosis is the hunchback, and lordosis is the sway back. You see that lordosis here. Osteogenesis imperfecta, it is the brittle bone disease, and you can see how thin these bones are. Very, very sad disease. My daughter went to school with a little boy that had osteogenesis imperfecta, and he pretty much lived in a wheelchair, because anytime the bones would heal, he would stand up to walk and he would just break a bone again, like it just from walking. Not anything extreme at all, but it's severe osteoporosis. Okay, weak muscles around those brittle bones. Very, very sad. Alright. That is it for chapter 21.